Slide is visible.
Yes, ma'am.
Okay, okay. Now we will start. Rashmi, এটা click করলে ফটোটা আসিব না? না এটি click করিয়া এটা। Okay, critical care unit. Myself P. Lakshmi Bai, Dr. P. Lakshmi Bai, Associate Professor, College of Nursing, Barampur, Ganjam District, Odisha. Okay. My total work experience 15 years in teaching and 15 years in clinical side. So I will also acquainted DCCN 3 batches already gone. Okay. What is critical care nursing? Now we will discuss. Introduction part is like that. Critical care unit CCU are designed to meet the special needs of acutely and critically ill patients. The delivery of the critical care originated from the need to centralize specially trained personnel and equipment in a separate area of the hospital to optimize the care of critically ill and injured patients. No hospital is complete without establishment of the critical care unit. This is totally how the critical care unit is established, and the critical care unit is designed to meet all the special needs of the acutely and clinically ill patients. Okay, suddenly the patient is acutely ill, critically ill, then only we admitted in the critical care unit, and that is originated from the need to centralize the specially trained personnel, those who are inside the hospital and as well as the ICU department. They are most probably most probably trained personnel and skilled personnel, and they are trained in the ICU setup, and all the equipments they are available as per the requirement of the patient's need, and this is separate from the ordinary hospital, and the ordinary hospital optimize care provided to the critically ill patient. How we will provide the optimized care? All total that is highest care provided to the critically ill patients, injured patients. No hospital is complete without establishment of the critically care unit. All are understood?
Yes, ma'am.
Yes. Then definition of the some of the terminology. What is critical care? The critical care means critical care is a term used to describe as the care of the patient who are extremely ill and those clinical condition is unstable or the potentially unstable. It may be unstable or the potentially in a we are anticipated that they are potentially unstable. That patient only termed as in the critical care units. Okay. Then next is critical care unit. You look the scenario. You also observe so many hospitals in the critical care unit like AIMS, and our hospital MKCG, MCH also having a big surgical unit, and ICU, surgical ICU, medicine ICU, NICU, neonatal ICU, CCU, all those are available. In the big hospital, private hospital also, they are available the all types of critical care unit. And critical care unit is defined as the unit in which comprehensive care of a critically ill patient which is deemed to recoverable stage is carried out. Okay. Then next is critically ill client. Okay, those who are life threatening condition, actually acute and potentially life threatening health problems, more ill and require more intensive and a careful nursing care, that patients are critically ill patients. Like the picture, we will see different types of patients. The patient having a nasogastric tube and all those tubing inserted, and ECG monitoring, and also railing the bed is comfortable for the patient. Okay, catheter also connected, the fluid also two sides connected, and CBP line also connected. These are the very ill patients. Then critical care nursing. Critical care nursing refers to those comprehensive, specialized and individualized nursing care services which are rendered to the patients with life-threatening or the potentially life-threatening conditions and their families. Okay. Then next comes to critical care nurse. The critical care nurse is a licensed professional. Now, ordinary nurse also have a licensed professional, and critically nurse also a specialized training. They are licensed in the professional nurse who is responsible for ensuring that acutely and critically ill patients and their families receive optimal care. Okay. Then evolution of the critical care nursing. Critical care. Critical care evolution, how it is evolved, why it is evolved. Okay, then these are the question arises in our mind. First is critical care evolved from an historical recognition that the needs of the patients with acute life threatening illness or injury could be better treated if they were grouped into specific area of the hospital. Then next is the evolution, the time period. 1920, Dr. W.E. Dandy established the first three-bed neurosurgical ICU at Johns Hopkins Hospital in Baltimore, USA. Okay, first in 1920, the evolution of the three-bedded neurosurgical ICU at Johns Hopkins Hospital in Baltimore, USA. Then after 1927, first premature infant care center was established in Chicago. Okay. Then next, shock was established for resuscitation of the patient during the World War II, 1939 to 1945. Then next, 1960, nursing shortage forced grouping of a post-operative patients in recovery area to ensure attentive care. Okay, then it leads to establishment of the recovery rooms in the USA hospitals. Okay, the nursing shortage forced grouping of the post-operative patients in a recovery area to ensure the attentive care. Attentive care only possible, attentive care only possible, or a comprehensive care only possible. That word must be a separate and a specialized. Post-operative care is highly essential after surgery. The surgeon is surgical procedure is done, but after that, the care is highly essential. That's why the attentive care, it leads to establishment of the recovery rooms in the USA in 1960. Okay. Then after 1947 to 1948, polio epidemic. Polio epidemic has been started. Then polio epidemic resulted in the dying of the patient from the respiratory paralysis in United States and Europe. United States, Europe. Then 1950, use of the mechanical ventilation. Okay, 1950, the use of the mechanical ventilation, iron lungs for treatment of the polio, development of the respiratory care units in the year 1950. Okay, these are the respiratory care unit, and these are the used for the ventilation purpose. That is iron lungs, called as a iron lungs. Then 1951, general ICU developed for the sick and a post-operative patients. Okay, in 1951, general ICU and developed for the sick and a post-operative patients. In 1960, critical care developed as a specialty in response to improve the patient outcome with ICU care, advancement in the post-operative resuscitation and monitoring. Advancement in the case of post-operative cases, if the patient is required resuscitation or continuous monitoring, or the surgeon's willingness to perform more ambitious ambitious procedure. Okay, these are the highly needed for the develop the specialty response, specialty care units. That's why it's, in 1960, improve the patient's outcomes, ICUs are created. Then next 1960 to 1969, most US hospitals had at least one ICU. Okay, at least one ICU in 1960 to 69. In 1970, formation of the Society of Critical Care Medicine, SCCM, in Los Angeles, California. Okay, in 1986, American Board of Medical Specialties approved a certification of special competence in critical care for the four primary board: anesthesiology, internal medicine, pediatrics, and a surgery in 1986. Then history continue between the 1990 and the present. Critical care significantly reduced in a hospital time as well as a cost. When ICU created, then significantly the hospital stay reduced, and as well as a cost also reduced during the 1990 to present situation. The development of the new and a complicated surgical procedures, such as a transplantation of the liver, lung, and a small intestine and a pancreas, created a new and important role for the critical care following transplantation. Organ transplantation time also necessary. The development of the so many types of complicated surgical procedures like transplantation, organ transplantation. That time also needed the ICU. Then widespread utilization of the non-invasive patients monitoring, pharmacological therapy for the critical care patients with a specific organ system failure reduce the time spent in the both critical care units and in the healthcare facilities. Then critical care practices in India. Indian scenario, critical care practices in India have evolved significantly over the past decade. As the most other developing nations, critical care medicines as a specialty has developed very slowly and recently in India. Then early to mid 1970 development of the coronary care units in India, and late 1970 first respiratory care units was developed by the Dr. Farooq E. Udwadia in two hospitals in the Mumbai, a community hospital and a private one, to bring down the mortality of the tetanus cases. Okay, tetanus patients. Then next comes to the few enthusiastic. trained consultants came together in 1992 to discuss the critical care on the common platform, and they formed the National Indian Society of the Critical Care Medicine, ISCCM. Okay, Indian Society of Critical Care Medicine. It has over 2000 members today and has 60 cities branches. Then post-doctoral fellowship. Okay, philosophy, fellowship, fellowship in critical care medicine conducted by the National Board of Examination has recently been announced. The training of nurses, technicians, and therapists has begun in some isolated foci, but has not evolved into a meaningful training activity. Okay, then critical care in India is those at a roads of the development. The field is full of a lot of dynamism, opportunity, and challenges. So many challenges they face. Then next comes to evolution of the critical care nursing. Okay, critical care only that time how it is evolved different scenario, and now we will discuss regarding the evolution of the critical care nursing. Following the Crimean War, 1854 to 1856, Florence Nightingale described the advantages of the specialized care for the recovery of the post-operative patient. If we will provide a separate and a recovery room and a specialized care to the patient, then the care is comprehensive, then only the patient recovery is very good and outcome also very good. At that time also, Crimean War, that point Florence Nightingale was described, and advantages of the specialized area for the recovery of the post-operative patients. Then to provide appropriate care, nurses needed specialized knowledge and skills, and the care delivery mechanism needed to evolve to support the patient's needs for a continuous monitoring and a treatment. Then the first intensive care unit emerged in the 1950 to provide the care to very ill patients who needed one care from a nurse. From this environment, the specialty of the critical care nursing emerged. As advances have been made in the medicines and technology, patient care has become the more complex. All you understand? Hello?
Yes, ma'am.
Yes, yes. Okay, okay. Thank you. Then classification of the critical care units, how it is classified, how the patients are sorting, and what criteria they must be in the admitted to the ICU. Okay, then first according to label of ICU, what is the level? First level, second level, third level. Okay, first level, patients having a monitoring, observation, short term ventilation needed. We will monitoring the patient by our observation, nursing hospital doctors observation needed, and a short term ventilation also needed. They are admitted in the level 1 ICU. Then second level, the monitoring, observation, and a long-term ventilation needed. Okay. Then third one is a intensive care invasive procedure. Any type of invasive procedure, invasive and a non-invasive. Here, the invasive procedure like central line any dialysis procedure or any type of the surgical procedure, invasive procedures. Okay, intensive care unit, invasive procedure, hemodialysis, and a constant support is needed. These type of patients, they are admitted in the level 3 ICU. Okay. Then according to second classification, according to way of the organizing ICU. According to way of organization means the traditional type, and second one is organ system, and third one is a client syndrome, and fourth one is a clientele. Okay, first one is a traditional means surgical ICU, medicine ICU, pediatric ICU. These are the traditional method. If the patient is serious any surgical procedure, then we will admitted to the patient in the surgical ICU. Medicine also like hypertensive, CBA, other any type of medical condition, then we will admitted to the patient in a medical ICU. Then pediatric also any serious child, that child is admitted in the constant observation by pediatric ICU. Then second one is a organ system, like system wise cardiac system, neurological system, renal system, respiratory system, or any other liver, or any kidney problem. These are the different types cardiac ICU. Now we will see in the hospital, different hospital, every department have a ICU, cardiac ICU, neurological ICU, neuro patients admitted in the neuro ICU, renal ICU, respiratory system any problem, then the patient admitted in the respiratory ICU. Then client syndrome like burn ICU, trauma ICU, stroke ICU. Okay, burn according to severity, we will 90% burn. The patient having a in a burn ICU unit. In a trauma accidental case, they are also trauma ICU. And a stroke patient, if severe occur, then the patient is severe condition, then respiratory difficulty, all those clinical symptoms, those are life threatening conditions, they are admitted in the stroke ICU. Okay, client clientele, that is neonatal ICU, pediatric ICU, gynec ICU. These are the different ICU, the clientele according to the neonatal, pediatric, and the gynec ICU patients are admitted according to way of the organizing ICU. Then classification of the critical care clients, patients. Okay, level 0, that is normal ward, level 1 at the risk of the deteriorating support from the critical care team. Then level 2, more observation or intervention needed to the patient, single failing organs or post-operative care. Level 3, advanced respiratory support or basic respiratory support, multi-organ failure. These are the cases admitted level 3. Then next, uh, yeah, ICU, CCU divided into two types. Basically, general ICU, CCU, general ward. Like medicine, surgery is a general ward. Then next is specialized. Specialized ward ICU, like neonatal intensive care unit, NICU, and special care nursery, SCN, pediatric intensive care unit PICU. Okay, coronary care unit CCU, cardiac surgery ICU SI CSICU, cardiac surgery ICU. Then neurosurgery ICU NSICU. Okay, now born intensive care unit, that is BICU. Trauma intensive care unit, that is also trauma accident case. General, in case of general medical intensive care unit, that is MICU. Then surgical intensive care unit, then medical surgical ICU, MSICU. These are the all ICU divided, critical care unit divided into general and specialized according to their organ wise. Okay. Then principles of Principles of critical care nursing. Okay, what are the principles we follow in the critical care unit? We are follow so many principles in the critical care unit. Anticipation. Okay, first principle is anticipation. Second one is a early detection and a prompt action. Second principle. Then third principle is a collaborative practices. Then fourth one is a communication. Okay, fifth one is prevention of infection. Sixth one is a crisis intervention, stress reduction. Okay, these are the principles we follow the in a critical care unit. If we will follow systematically, then every patient got their sufficient comprehensive care, holistic care. Okay, one by one we will discuss. Anticipation. What is anticipation? One has to recognize the high risk patients and anticipated the requirements, complications, and be prepared to meet any emergency. Unit is properly organized in which all the necessary equipments and supplies are mandatory for the smooth running of the unit. The if patient is admitted in the ICU, then the ICU as requirement of the patients, every need the ICU will be fulfilled. Then they required the any they develop any complication or a potential complication arises, that also they meet. Prepare for any emergency, they meet the any emergency. Unit is properly designed or properly equipped, and also supplies are mandatory for the smooth running of the unit. Every resource person also available, and as well as every situation they meet the situation. The completion arises, then they solve the problem. Okay, this is known as a anticipation. Then second is early detection and a prompt action. If the diagnosis is early done, diagnosis what is the problem, find out, then prompt action will be taken. So early detection, early find out the problem, then after prompt action we will take. Okay, the prognosis of the patient depends on the early detection of the variation, prompt and appropriate action to prevent or the combat the complications. Monitoring of the cardiac respiratory function is of the prime importance in the assessment. This is the second principle. Then third principle is that is collaborative practices. Everywhere you know that hospital is a collaborative practices, but the critical care unit, the collaboration is highly essential. Critical care, which has originated as technical and a sub-specialized body of knowledge, has evolved into a comprehensive discipline requiring a very specialized body of knowledge for the physicians and the nurses working in a critical care unit. Collaborative practice is more and more warranted for the critical care, more than in any other field. Okay, a collaborative practice, if not there, then the patient is not properly treated. So every department, every pathology, pharmacology, and medicine, every specialized knowledge person are collaboratively work together in the ICU setup. Then communication. Communication is highly essential in the ICU setup because intraprofessional, intra-departmental, and intrapersonal communication has a significant importance in the smooth running of the unit. Collaborative practices of the communication model also it is utilized properly in this setup. Okay. Then prevention of infection is the fifth principle. Prevention of infection. Critically ill patients require intensive care, care are at a greater risk than other patients due to immunocompromised state with the antibiotics uses and stress, invasive lines, mechanical ventilator, prolonged stay, and severity of the illness, and involvement of the critically unit itself, because prevention of infection is very important in the critically patient, because the patients having a immunocompromised state, more than one organ also failed in that patients, and they are very much stressed, and so many invasive lines are connected, mechanical ventilator, and also prolonged stay. Okay, according to severity, according to illness, their stay also prolonged. Environment also critical itself. Okay, different types of sound and different types of patients are stay in the one setting. Okay, the critically ill patients requiring intensive care, that is a greater risk of the infection. Then next comes to crisis intervention and stress reduction. This is also sixth principle of ICU. The crisis intervention, any type of crisis, then the patient's intervention will be given. Any type of crisis release, how to crisis release, and a stress also reduction. Partnerships are formulated during the crisis. Bonds between the nurses, patients, and families are stronger during the hospitalization. As the patient advocates, nurses assist the patient to express fear and identify their grievings pattern, and provide avenues for the positive coping. Okay, these are the different situation, that situation needed the stress reduction and a crisis intervention. If the patient is in a very much stress, then the disease is also severity increase. So at that time, how the stress is reduced, and every patients and their family members and also nurses, they are closely interrelated. They are advocating, counseling. Okay, then seven C's of the critical care. Okay, seven C's of the critical care. C means compassion, communication, consideration, colleagues, and avoidance of the conflict, comfort, prevention of suffering, carefulness, avoidance of the injury, consistency, closure. Closure means ethics and a withdrawal of the care. These are all seven C's interrelated in the critical care nursing. They are provided all this compassionate care and a communication with patient and the family members, consideration to the patient, relatives, and the colleagues, and avoidance of the conflict. Any type of conflict arise, then avoidance of the conflict, and how patient is comfortably, prevention of suffering, and carefulness also apply, avoidance of the injury, consistency care also provided, closure, that means ethics and a withdrawal of the care. Then these are all regarding the concept of the all total critical care nursing. It may seem a strange principles of the enunciated articulate as the very first requirement in a hospital, that it should do the sick no harm, according to Nightingale 1859. Okay, then next topic is CCU organization. Okay, CCU critical care nursing unit organization. Establishment of the critical care unit requires intelligent planning. Okay, if we are establish the critical care units, require the intelligent planning. One CCU may not cater to all the needs. An institute may plan beds into multiple units under the separate management by single discipline specialist. That is example medical ICU, surgical ICU, born ICU, CCU, trauma CCU, etc. Different types of according to different classification they are organized the total traditional method and according to their disease condition and according to system wise also different problem, then ICU planning like that. Then CCU organization. First CCU, if we will create a CCU or organize the CCU, first is a physical setup. Okay, physical setup. Second one is a staffing norms, and third one is a different types of policies required for the CCU organization. Okay, physical setup, staffing norms, and a policies. Different policies. Physical setup mainly location and the size of the ICU. Okay, location, how what location it will be organized, and the size, how many beds. Okay, size of the ICU. Then auxiliary area, ancillary area, patient care, patient area. These are the four physical setup. One by one discussion. Then location and a size. Okay, location centrally located in the hospital, easily approachable, away from the hospital traffic. Okay, restricted entry. Anyone those needed only they are got the pass. Then after they enter the hall. Okay, restricted. Like general hospital, they are not enter the ICU. Away from the hospital traffic. Hospital traffic is very full of patients and their relatives, so away from the hospital traffic. It mostly easily approachable and also centrally located. That's why it's a location like that. Then size of the hospital, size of the ICU or SSU. Super specialty hospital, that is 10% of the total bed. Okay, super specialty hospital, that is 10% of the total bed. Then general hospital 2% of the total bed. Then optimum bed 14 beds and minimum beds is 4 beds. Optimum bed is 14 and minimum bed is 4. Like the CCU or a size of the CCU or a ICU. Okay. Then next comes to patient care area. Patient care area means first is bed space. Okay. How the space between the two beds, bed space. Okay. Then open tissue, that is 100 to 120 square feet. Cubicle 140 to 180 square feet. Clear area 15 square feet. Then head wall space 1 to 2 feet. Then space between the two beds 5 to 8 feet. These are all the size of the bed space. Then next comes to nursing monitoring system. The nursing monitoring system, then call bell system, then wall fixers, oxygen, air, and suctioning, and power outlet. These are all fixed in the wall. When you see the observe in the ICU, then oxygen, three oxygen, two air, and two suctioning, power outlet. These are the all fixed in the walls. Then next comes to hand washing procedure. Every situation wash the hand is a highly essential, because every patient is a immune compromised, and one patient to after one patient we will go, then that must be infectious. So hand washing is necessary. Standard precaution maintained. Equipments also all those equipments, those are required for the patient care. All equipments, bedside also available. This is the model of one of the ICU. Okay, ICU setup centrally, nursing station. Then after cubicle, side bed each cubicle, and the total requirement also there. Then equipments. Okay, equipments, monitoring the equipments, supportive equipments, general equipment, resuscitative equipments, general monitoring equipments. Okay, general monitoring equipments, all monitoring equipments required. And if the patient highly life threatening condition any time, resuscitation also essential. So resuscitative equipments also necessary, supportive equipments also necessary, and general equipments. Then monitoring of the equipments. What are the monitoring? The monitoring equipment, ECG monitoring, pulse oximeter, and the different X-ray machines. Okay, EEG machines, ECG machines. These are the monitoring equipments. All are seen in the ICU setup.
Yes, ma'am.
Yes, ma'am.
Okay, okay. Thank you. Then manual BP machine, okay, blood pressure machine, and a digital BP machine, and invasive BP monitoring. These are also available in the ICU setup. Then CBP kit, okay, central venous pressure kit also available, and a temperature, that is pulse oximeter, and a skin temperature. These are the all required equipments. Then next is the peak, then cardiac output monitoring, then different types of chamber pressure monitoring. These are all equipments, advanced equipments available in the ICU setup. These are the different syringe pump. Okay, setting the small drop of injectable is setting in this way. The infusion pump. Okay, ABG machine, ABG analysis के लिए ABG machine also available in the ICU. Patient bedside also ABG they are done, and then after they immediately they are treated. Then resuscitative equipments, defibrillator, nebulizer machine, humidifier, temperature temporary pacemaker. Okay, pacemaker. These are also resuscitative equipments. Then equipments for oxygen administration. Okay, oxygen cylinder, catheter, and ventilator machine. Okay. Then next is laryngoscope. You all seen in the general ward as well as ICU also. Laryngoscope, ambu bag, ETT, ETT having different size for adult and children. Okay. Then crash trolley in all types of emergency drugs. According to their chamber, they are available, and labeling the each chamber, which drug is kept in which chamber. This is a crash trolley for life saving. Okay. Then supportive equipments, portable X-ray machine, and a CCU bed, and a portable X-ray machine, and different types of vein plumb, and syringe needles, dialysis equipments. These are the supportive equipments required, and they are available in the ICU setup. Okay, all you've seen. Then cardiac board, and bed restraints. The patient having a bed restraints because they are not any type of if, fits or any type of a problem arise, they are fixed in the bed. Then bed restraints. Okay, these are the bed restraints. Have you seen these patients?
Yes, ma'am.
Yes, ma'am.
Okay. Then air mattress, warmer, and a drip stand. Drip stand always we will see. Then dressing trolley. Okay, all those things available in the dressing material. Then next sterilizer, autoclave, okay, warmer, refrigerator, all these are the equipments available in the ICU setup. Then clock, calendar, okay. Then different size general equipments like syringe, venplum, and physiotherapy machines. Then police catheter according to their size, CBP line, and drainage tube. Then next comes to auxiliary area. Auxiliary area contains medication and a nursing area. Okay, medication nursing area. Second one nursing nurses changes area. If the nurses are putting their home dress, they change the dress. Then after they enter the ICU, CCU. Okay, nurses changing area. Doctors duty room, then dressing room, a store room, then equipment maintenance room, then after any utility room that the things are collected from the patient under the utility room area they are collected, and then after they next comes to entry. Okay, nutrition purpose pantry area also available, isolation area also available. In a medical environment, air condition must be air conditioned to temperature 25 to 27. That is 40 to 50 percentage humidity. Okay, temperature 25 to 27 and 40 to 45% humidity. Air condition. Then medical environment, lightning. If the lightning is low, dim, then every procedure not done perfectly. So lighting, varying degree of the illumination, intensity 1 to 30 lumens, glare free, provision of the dimmer lights. Okay. Then next comes to noise free, and a soft and a light music, TV and a clock, walls reflection free, floor mosaic, etc. Then comes to ventilation 6 to 8 air changes per hour. Then auxiliary area. Okay, auxiliary area that contains the CCU matron's office, critical care unit, matron's office, auxiliary. Then staff toilets, okay, staff restroom, telephone facility, then office space. These are all regarding the auxiliary area. Okay, auxiliary area contains the CCU matron's office, staff toilet, staff restroom, telephone facilities, and a office space and a record from. Record all those documents, official documents in the ICU, CCU patients documents. These are very essential for the reference, for the reference, and also these are kept in the very accurately. Okay, accurately they are kept. Then different policies used in the ICU. Okay, policies like admission policy, then treatment policy, staff standing order, and quality assurance. Anything quality assurance is also necessary in the ISO discharge policy. Okay, these are the policies. Uh, the one by one. Admission policy. What is admission policy? The criteria for the admission. What is the criteria? First is major operation requiring vital monitoring. Okay, major operation requiring vital monitoring. After operation theater, the patient is admitted in the ICU after recovery. Then only they come to the general ward. Okay, you will see in the hospital side also, when major operation done, at that time the patient is admitted in the ICU 1 or 2 days. Then after they come to hospital. Then intermediate ward. Okay, then requiring the airway support, artificial ventilation. Okay, then admission policy. Second one is a hemorrhagic. The patient is a hemorrhagic shock, electrolyte imbalance. Those patients having a shock, any hemorrhagic shock or a electrolyte imbalance, any type of mass accident, the patient having a severe hemorrhagic condition or a shock condition or a electrolyte a severe dehydration, then patient having a electrolyte imbalance. At that time, the criteria is admission policy, admitted to the ICU. Then next is toxemia and septicemia. The condition is very life threatening, so toxemic case and septicemia case also admitted in the ICU. This is also one policy. Transplantation patient. If the organ transplantation is done, then the patient is admitted in the ICU for the stable condition. Okay. These are all trauma, head injury. The case also severe head injury or a severe traumatic injury, then they are admitted in the ICU. These are the admission criteria. Then treatment policy. Treatment policy, admission only on recommendation of the CCU. Okay, director, or a vacant bed is allocated in a original ward for the patient return, and 20% beds to be kept vacant for emergency admission. So all total beds 20% always vacant for the patient having a emergency admission. Continuity of the treatment is for view of the CCU in charge in consultation with the unit in charge. Following standard treatment protocol, observation of the silence, and a registration of the new admission and a discharge. These are all regarding the treatment policy. All are understood?
Yes, ma'am.
Okay. Staff standing
Yes,
order.
ma'am.
Staff standing orders. Standing orders join the round at the time of staff change. Instruction and maintenance of the intake output chart. That cleaning and maintenance of the equipment, checking and replacement of the essential drugs, proper maintenance of the record, daily round of physician and IC of CCU combined to take decision for the change in the treatment. Okay, staff standing order. These are the staff standing orders. Then discharge policy. Decision to discharge is taken in the consultation with in charge patient parent unit. Then patients who have recovered stable and does not require artificial ventilation can be shifted to intermediate care or the intermediate care units or the hospital department total means unit. Then patient who are not under not progressing and changes of the recovery chances of recovery is remote to the discharge for allotting bed demand is accurate. Okay, when there is no demand, patient is kept in the CCU till death. These are the all discharge policy of the CCU ICU. Then quality assurance is also one of the important aspect in the hospital and ICU also, to maintain high standard of the hygiene and the cleanliness, to prevent hospital acquired infection, proper treatment and a disposal of the biomedical waste management, daily maintenance, checking vital equipment, priority on the patient comfort and the home feelings, exit the interview of the patients and relatives to release standard and a quality care. Okay, increase standard and a quality care. Then staffing norms. Staffing norms also, the nursing staff, then after medical staff, staffing, then ancillary staff, then technical staff. Okay, nursing staff, medical staff, technical staff, auxiliary staff. Okay, head of the department. First is head of the department, hospital head of the department, director CCU, critical care unit. Then after physician 24 hours, ANS and ANS, then technical staff, receptionist, safety officer, okay, biomedical engineer, biomedical technician. Then after technical staff, including the respiratory therapist, physiotherapist, ICU technician, lab technician, then ANS, nursing staff 24 hours, then supporting staff. Okay, these are the chart for the organizing chart of the CCU. Then staffing required per shift in ICU, nursing staff, medical staff. Nursing staff mainly 1:1, nurse patient relationship 1:1 ratio during the day, nurse patient ratio during the night 1:2. Okay, one patient to 1:2. Then 4 to 5. 4 to 5 during the night, 4 to 5 nurses per bed, including the reliever. One ANS for admission. Okay. Then medical staff, one physician for 5 bed, consultant CCU one, senior resident one, junior resident one. These are all regarding the staff requirement for shift in ICU. Okay. Then next comes to role of the nurse in ICU. Okay, role of the nurse in ICU, that is mainly how the nursing personnel, what is the role, how they are perform their role in the, what are the requirement of the patients and how they working in the according to need of the patient. The trained nurses has become the one of the greatest blessing of humanity, taking a place beside the physicians and other priests, according to William Osler. It is correct or not? Hello, hello,
Yes, ma'am.
everyone.
Yes, ma'am.
The
Yes, ma'am.
trained nurse has become one of the greatest blessing of humanity, taking a place bedside, okay, and other priests. William Osler.
एक पीडीएफ व्हाट्सएप में सेंड करेगा तो अच्छा होगा.
Okay. Hmm? Hello. Any problem? Hello, student.
No, no, ma'am. No, ma'am. Please carry on.
Okay, okay. Then function of the skilled nurse. Okay, what is the function? How they perform their work in the ICU, CCU. Okay, some of the basic function of the CCU. CCU nurse are assessing the patient's condition, implanting appropriate care or implement the appropriate care, then treat the wounds, administering the IV fluids and medication, monitoring the patient, managing the ventilator, monitors and other equipments, and performing the defibrillation, then providing the utmost all the comprehensive care, then maintaining the arterial lines and pressure interpretation, then control the infection control ICU, then providing the patients and family teaching, then interpret and other diagnostic laboratory test, and make nursing diagnosis using the standard and protocol for the treatment. Okay, these are all the requirement for the as a nursing personnel in the nursing care, and keep the emergency equipments ready. Then assisting the physician in performing their different procedures also. Okay, immediate care. Immediate care mainly initial immediately. First we initially assess the patient according to nursing process also. Assessment first step, then immediate management, then initiate the initial investigations, then monitoring. Okay, the four things are always did in the ISOCSU, a comprehensive healthcare patients of the critically ill patients health status, history of the comprehensive history, patient total past history, present history, critically ill patients health status is important to find out the risk factor. Okay, history taking, then adequate knowledge on the assessment can make sure about the patient's vitals, neurological status, and also pain score. Then next is the nurse should assess the A, B, C, D, E, airway, breathing, circulation, defibrillation, exposure of the patients. Then patient immediately after receive the patients. Okay, then airway also upper respiratory obstruction by the tongue. If the snoring is there, upper respiratory obstruction. According to their symptom, we find out the what is the problem of the patients. Then next is clear airway. Then ruling upper airway obstruction by liquid, any type of liquid. Then suctioning, then stridor obstruction by foreign body or a stenosis of the upper airway. Then after we know the removal of the foreign body or intubate the patient. Then who is present spasm of the small airway, that is either bronchodilator necessary. Then silent competitive way obstruction occur, then intubate the patient. Okay, these are all airway. Then next is breathing, respiratory breathing. If the clinical feature of the respiratory distress, breathless, tachypnea, then inability to talk, open mouth breathing, flaring of the nose, paradoxical breathing, use of the accessory muscle for respiration. These are the clinical feature of a respiratory distress. And clinical feature of inadequate oxygenation, patient having a restlessness, delirium, drowsiness, cool the extremities, cyanosis, tachycardia, arrhythmia, then hypertension. These are all regarding the breathing pattern. We assess the patient. Then circulation. Look at the color of the hands and the digits. Assess the limb temperature. Limb temperature. Then measure the capillary refill time. CRT. Okay. Capillary refill time. Assess measure. Then assess the state of the veins. They may be under the field or the collapsed when hypovolemia is present. Okay, assess the state of the veins. They may be under the field or the collapsed when hypovolemia is present. Then palpate the peripheral and central pulses. Measure the patient's blood pressure. Then auscultate the heart. Then look other signs of the poor cardiac output, such as a reduced consciousness level. Reduced consciousness. These are all circulation regarding C. Okay. If the patient having the color of the hands and the digits, the discoloration or a cyanosis, or the limbs according to temperature criteria, and capillary refill. CRT also we measure and study the veins. Veins may be hypovolemia or a collapse, or the palpate the peripheral central pulses, and a patient blood pressure also we will take. Auscultate the heart. If any condition is deteriorate or any type auscultation is not properly seen, and other for the cardiac output. Okay, other situation, conscious level also we find out according to circulation. Then next comes to manage of the circulation. Management of the circulation, judicious use of the volume and inotropics and vasopressors according to physician's order. Okay, pericardial tamponade. Pericardial tamponade, the immediate pericardiocentesis. Immediate pericardiocentesis. If the patient having pericardial tamponade, then immediate pericardial synthesis down. Then pulmonary embolism. If patient having a pulmonary embolism, then urgent anticoagulation, then investigation will be done. Then dissection. Aortic dissection occur, then urgent control of the hypertension and the heart rate. Then sepsis and a septic shock. The septic shock occur, then broad spectrum biotics and a resuscitation will be done. Then patient is hypovolemic shock or a cardiogenic shock or a spinal shock. Then the according to shock, what is the cause? Find out. Then after we different procedure adopted for the light saving. Then next comes to measure of the level of consciousness by using the ABPU method. Okay. Then A is alert, V is verbal asking method, P is pain assess, unresponsive, U is unresponsive, unresponsiveness, and check the pupil size and the functioning of the response. Then assess the motor and a sensory response to all the four limbs. Okay. Then next comes to head to toe examination. Look for any sign of the hemorrhagic, bruising, infection, injury, etc. Then examine for the gross neurological deficit. If any gross deficit occurs, then the basic conditions investigate during the initial resuscitation, then CBC, then blood sugar, okay, electrolyte, urea, creatinine, LFT. Investigation during the initial resuscitation stage, CBC, blood sugar, and electrolytes, urea, creatinine, and LFT will be done. Then coagulation profile, ABG, okay, chest X-ray, 12 lead ECG, and appropriate microbiological culture. These are all. Then continuous monitoring mainly include the regular reviewing the patients, enhancing the elements of the safety and the comfort of the patient care in a CCO. Then while monitoring the patient condition, the nurse should follow the mnemonic fast fuse. Okay. All you know that fast fuse. What is fast? Fast hog, full form of the fast hog. Anyone from the group, while monitoring the patient condition, the nurse should follow the mnemonic. Okay. Hello, hello, students.
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Yeah. Fast hog.
Yes, ma'am.
What is that? Fast hog. F for feeding. Okay. F for feeding. A for analgesia. S for sedation. Then T for thrombolytics. Thromboembolic prophylaxis. Okay. H for head of bed elevation. U for ulcer prophylaxis. And G for glycemic control. Okay, fast huge. These are the monitoring nursing when ICU monitoring at that time. She is memorized. Thank you. Okay, fast hug. Fast hug means feeding. F for feeding. A for analgesia. Any type of analgesia. S for sedation. E for thrombolytics. Prophylaxis. H for head of the bed.
Elevation.
Okay, head of the bed elevation. U for ulcer prophylaxis. G for glycemic control. These are all the monitoring process. Then next, fast hog mnemonic checklist, which should be employed every day by the nurse during the care of the critically ill patient. Then next, feeding. Okay, FAST, fast feeding, analgesia, sedation, thrombolytic. All those had to. Okay, these are the full form. Then next, extended role of the critical care nurse. Clinician, all you know, clinician, practitioner, educator, all nursing in the hospital also their role is a clinician, practitioner, educator, manager, mentor, advocacy. When required any time the counseling is necessary, advocacy the patient, counselor, researcher. Okay, one by one. Clinician means, what is that? As a nurse clinician, she is responsible for identification and intervention of the clinical problems and manage those problems to improve the care for the patient and families. Then second one is they provide direct comprehensive patient care. What is mean by comprehensive? What is comprehensive? Say anyone from the group. Comprehensive means a direct comprehensive, provide direct comprehensive patient care. All total, okay, all total care. Total physical, mental, social, spiritual, all total care to the patient. Comprehensive care and a prescribing pharmacological and non-pharmacological treatment of the health problem. What is non-pharmacological treatment?
Positioning changing, physiotherapy,
Yes, yes, very good, very good. Positioning changes, massage therapy, music therapy,
occupational,
acupressure, any type of non-pharma. Without medicine, we will provide the care, treatment to the patient, solve the problem. Okay. According to doctor's advice, physician's advice, we provide the pharmacological treatment and non-pharmacological treatment, our nursing interventions. So different types of nursing interventions. Okay. Then
yes,
comes to practitioner. Nurse practitioner is a registered nurse with additional educational preparation and experience. Then he has two competencies to autonomously diagnose the order. interpret the diagnostic test, prescribe the pharmaceutical, and perform the specific procedure within the legislative scope. That is a practitioner role. She is trained in advanced skills like, what are the advanced skill? Chest tube insertion, okay, then ventilator management, intubation, arterial gases, then second, next is work is manager. Manager, the nurse manager is responsible for both the clinical and administrative aspects. Okay, clinical and as well as administrative aspect. Matron in the hospital, clinical as well as administrative. And she is in charge of the daily operation. Okay, daily operation of a nursing unit within the hospital. Then the main function of the manager are create shift schedule, okay, schedule preparation, and create the departmental budget and track monthly expense, purchase of the equipment and supplies, and ensure the safety equipments and work environment. These are the manager role. Then educator, all you know, educator is the how to provide education to the patients. So clinical nurse educator is a registered professional nurse with advanced clinical and educational experience. Then she should complete the postmaster degree in the nursing, and she educate health personnel on a new treatment protocols which improve the disease outcome. And she educate the patient and family on a different treatment modalities and how to manage the particular disease. Then advocacy. Okay, advocacy is also one of the role of a nurse. As advocacy, the nurse protects the client's human and legal rights, and the nurse explain the what is likely to happen and reason for the test or the procedures which make client confidence and promote the healings. Then she provides a safe environment for the client, takes steps to prevent injury and protect the clients from the possible adverse effect or measures. Okay. Then counselor. Counselor always counseling the patient helps the clients and to recognize and cope the stressful psychological problems and give stress management and grief counseling. Then focus on helping client to develop positive attitude and provide emotional, intellectual and psychological support. Always nursing person helping the client to develop positive attitude, provide the emotional support, emotional care, and intellectual and psychological support to the patient. Okay. Then researcher. Always research is very important in the medical field. So researcher is a vital aspect of the health services and essential to the provision of the effective, effective and a safe health and a social care. Then the role of the nurse is to conduct clinically relevant research and the integration of the research finding into nursing practice, particularly within the patient setting, evidence-based practice, okay, patient setting. Then next, to maintain objective of the clinical research to improve the patient quality of care. In the through research, the if the objective is fulfilled by the patient to improve the patient's quality of care. Main aim of the research is to improve the patient quality of care. Then next measure is infection control. Okay, one of the role the nursing personnel in ICU issue infection control. Then it is the measure practiced by healthcare personnel to prevent spread of the infection between the clients from the clients to the healthcare providers. Then next risk factors leading to leading to hospital associated infection. HAIS. Okay. HAIS means hospital associated infections. This factor leading to hospital associated infection. Then impaired host defense, then severity of the illness and the length of the stay hospital, then invasive devices, okay, then cross infection. These are the impaired host defense. Impaired মানে host যে ଅଛି, the host is impaired, the defense mechanism impaired to the host. Host means here the patient. Okay. Then severity, due to severity of the illness, length of the stay. If the patient is prolonged time in the hospital, it is also impaired the defense. Every time multi-organ failure patient have required so many invasive procedures, devices, and a cross infection also occur in the hospital. These are the risk factors leading to hospital associated infection. Then mode of transmission. Contact, by contact, direct contact, vector borne, okay, vector borne, airborne, then droplet infection, sneezing, coughing, droplet infection, by vector borne, by bite of the mosquito or any other organism. A direct contact also occur. Then agents of the nosocomial infections like virus, bacteria, fungi, these are all the agents. Okay. Agents of the nosocomial infection, virus, bacteria, fungi. Standard precautions for infection control. Standard precautions are the set of the infection control practices used to prevent the transmission of the disease that can be acquired by contact with blood, body fluids, non-intact skin, mucous membrane. These are the measures are to be used when provide care to the all the individuals. Standard precaution always used in the um, hospitals. Okay, what are the standard? Hand hygiene and personal protective equipment, PPE, then respiratory hygiene, then safety injection practices, okay, safe injection practices, then handling of the sharps, different sharp instrument, how to handle if they are any type of cut or any type of injury to the human being, then only disease occur. Then waste management, biomedical waste management. Okay, these are the standard precautions, mainly hand hygiene, PPE, wearing of the PPE, respiratory hygiene, safe injection practice, safe handling of the SARS, and a waste management. Okay, pre and post prophylaxis, then immunization, standard precautions. Okay, then hand hygiene. How we will know that hand hygiene is highly essential every procedure. Hand hygiene is the most important way to reduce the spread of the infection in the healthcare settings. Then it reduces the number of the infectious microorganism on hands and also reduce the client sickness and death caused by the infection. Then next comes to respiratory hygiene. Okay. PP also use how the PP is wearing gloves, masks, and gown. Okay, PP also properly use the PP. Then next comes to respiratory hygiene. These are all you have read in the infection prevention also. The fourth block, 31 fourth block, infection control also high, they are elaborately you will continue the course. Okay. Respiratory hygiene. Respiratory hygiene is directed to patient and family members with signs of the respiratory illness such as cough, congestion, or the increased respiratory secretions. Then use of the mask for the person who is coughing is necessary. Okay, then there should be a spatial separation of the person with the respiratory illness at least 1 meter or 3 feet away from the other in common waiting areas. Safe injection practices. Okay, safe injection aseptic techniques and use of a single syringe and a fluid infusion sets only once. Then using the single dose vials when possible. If multi-dose vials must be used, then use of the store them according to manufacturer. Okay. Then next, dispose of all the sharp instruments used during the procedure immediately, carefully and appropriately. Then the sharps container never be overfilled and then disposed after three-fourth filled. All you know that in the hospital setup, three-fourth filled, and then after the container is not overfilled. Okay, the sharp container must be securely sealed, sealed with a lid. Before disposal, use utility gloves during the disposing the sharps. Hospital waste. Um, Now should aware about the types of the hospital waste and segregation of the different types of the waste and how to treat the infectious waste. Okay. Then post exposure prophylaxis. Post exposure prophylaxis is a preventive medical treatment standard immediately after the exposure to the pathogens in order to prevent the infection by the pathogens of the developed disease. Okay. Then rabies vaccine or tetanus toxoid, hepatitis B virus, these are the all vaccination. Pre-exposure. Okay, pre-exposure prophylaxis. Pre-exposure prophylaxis is the pre um, preemptive use of the drugs to prevent the disease in the people who have not been exposed to disease causing agents. Then immunization against the hepatitis B virus must be provided to the hospital worker who perform tasks involving the contact with the potential infectious blood or other bodily fluids. This is all about the our today topic. The topic is mainly the concept block one, uh, the BNS-031 का concept and principles of the critical care nurses. Okay.
Hello, ma'am.
Hello.
Ma'am, please share this PDF in WhatsApp number.
Okay. Okay. You prepared one group WhatsApp group.
Yes,
Then
मैम
on
ma'am.
मैम ग्रुप प्रिपेयर करके लिंक चैट बॉक्स रे दे देछि जो
ଦେଇଛନ୍ତି
लोग
କି
भी
ଯୋଉ
यस यस
ପିଲା
मैम
ଅଛନ୍ତି ଯୋଉ ପିଲା ଅଛନ୍ତି ଆଡମିନ କୁ ପ୍ରିନ୍ସିପାଲ ଙ୍କ ନାଁଟା ରଖ ମୋ ନାଁଟା ରଖ ଓକେ
ओके ओके मैम
ହଁ ହଁ ଦି ଜଣଙ୍କ ଦି ତିନି ଜଣଙ୍କ ନାଁ ରଖିଲେ 4 ଜଣ ଅଛନ୍ତି ଗ୍ରୁପ ରେ
हाँ
ପ୍ରିନ୍ସିପାଲ
मैम
ମ୍ୟାଡମ
मैम सब मैम
Just
को
message,
एडमिन कर रहे
just share
ରିନୁ
this, share my number, please.
ହଁ ହଁ ରିନୁ
I
ମ୍ୟାଡମ
can share this group.
ओके रिनू मैडम अच्छा ମୁଁ ଅଛି ସସ୍ମିତା ପାଢୀ ମ୍ୟାଡମ ଅଛନ୍ତି ରାଜଲକ୍ଷ୍ମୀ ମ୍ୟାଡମ ଅଛନ୍ତି
ओके
ତେଣୁ
मैम
4 members in your group decision any problem you arise then you ask the group we are replying okay and now continue your classes 12 classes will be done today is a first class then after tomorrow rinu madam lenge और डे आफ्टर प्रिंसिपल मैडम सस्मिता
ऑफिशियली तो
मैडम
कोई ग्रुप नहीं है ना.
हाँ
नहीं दे
ऑफिशियली
आर
हम लोग वो बताएंगे कि
ऑलरेडी
आप
वी
बताएंगे
already we
वही तो
create a
बोल रहे हैं
group
मैम.
and we give a link to chat box huh? Please join all
decision 2025 इस ग्रुप का नेम ऐसा रखो, 2025 डिसीजन, देन
ओके
ओनली
मैम, ओके
वी
मैम।
नो। क्योंकि पिछले बैच का 2024 का बैच है, 23 का बैच है, 25 का ये बैच है। ओके। और बाद में प्रैक्टिकल शेड्यूल भी आएगा, प्रैक्टिकल कैसे कैसे, शेड्यूल 1, शेड्यूल 2, जो 3 ग्रुप में डिवाइड हुआ है प्रैक्टिकल का। ओके। तो
ओके मैम।
दो स्पेल में बच्चे आएंगे, क्लिनिकल करेंगे, और जो भी असाइनमेंट सबमिट करना है, और प्रैक्टिकल सुपरवाइजरी एक्टिविटी, और हमारा सेल्फ एक्टिविटी, वो दो सब करना पड़ेगा तुम लोगों को।
मैम
हाँ, बताइए। हाँ, कुछ प्रॉब्लम?
मैम प्रैक्टिकल कितना दिन का लगा होगा?
प्रैक्टिकल यहाँ एमकेसीजी में ही होगा, डिफरेंट आईसीयू, सीसीयू और डिफरेंट
कितना
वार्ड।
दिन के लिए?
हाँ, कितने दिन के लिए वो शेड्यूल जाएगा, मैम ने बनाया था वो शेड्यूल। तुम्हारा आज पर सब्जेक्ट वाइज कितना आवर हमको प्रोवाइड किए हैं, 33 का कितना आवर, 34 का प्रैक्टिकल आवर, इसीलिए 33, 34 पहला टोटल 20 डेज, आप देन आफ्टर सेकेंड स्पेल में 18 डेज।
तो इतना दिन तो छुट्टी नहीं देगा, हम लोग तो जॉब कर रहे
तुम्हारा कोर्स में इतना दिन है, 20 डेज एक स्पेल में, 18 डेज एक स्पेल में।
इतना दिन तो छुट्टी नहीं देखेगा मैम हम लोग।
हम लोग देखेंगे फिर।
7 डेज होगा तो अच्छा होगा।
7 डेज नहीं होगा, पिछले बार तो कम दिन हुआ, इसीलिए थोड़ा आवर बढ़ा दिया।
हाँ ठीक है मैम, देखिए एक बार।
हम्म। ऐसे तो क्लिनिकल साइड में आप दूर दूर से जो बच्चे आएंगे, वो बच्चे के लिए तो क्लिनिकल साइड में इतना ज्यादा छुट्टी भी नहीं मिलता है, लेकिन क्या करें, कोर्स के लिए कुछ तो छुट्टी लेना पड़ेगा। तुम्हारा तो ईएल होगा ना, सीएल ईएल, कुछ छुट्टी मिलाकर ऑफ।
नहीं, इतना भी नहीं देगा कंटिन्यू मैम, यही बात है।
हाँ हाँ।
प्राइवेट सेक्टर में नहीं देता है मैम, प्राइवेट हॉस्पिटल में।
हाँ हाँ, गवर्नमेंट सेक्टर में है, लेकिन प्राइवेट में थोड़ा प्रॉब्लम
प्राइवेट
होगा।
में 7 डेज में भी देना के लिए तो आसान है।
हाँ हाँ हाँ। मैम के साथ बात करोगी वैसे, प्रिंसिपल मैम है ना?
हाँ ये थोड़ा बात हो रही है मैम, क्योंकि प्राइवेट
हम्म
ज्यादा स्टूडेंट भी प्राइवेट हॉस्पिटल में जॉब करता है, तो उन लोग को 4-5 दिन ऐसा कुछ मिलेगा बस।
हम्म।
हाँ
बहुत ज्यादा प्रॉब्लम है। तुम्हारा बुक सब मिल गया तुम लोगों को?
यस मैम।
हाँ,
यस मैम।
तो बुक ब्लॉक 1 में बहुत ज्यादा है, इतना तो ज्यादा हम लोग कर नहीं सकते, लेकिन कुछ कुछ जो भी डाउट है तुम पूछ सकते हो। ओके। वो बुक में जो जो थिंग्स है, और प्रिंसिपल मैंने 6 प्रिंसिपल बताया, लेकिन उसमें और ज्यादा भी प्रिंसिपल तुम्हारा बुक में, डिसीजन का बुक में है। वो एफिशिएंसी, कंटिन्यूटी, वो सब भी प्रिंसिपल है, एक एक प्रिंसिपल है हमारा। मेडिकल सर्जिकल क्रिटिकल केयर में यही प्रिंसिपल है। पेशेंट नीड्स, सोशल कल्चरल,
मैम गुड आफ्टरनून मैम।
हाँ, गुड आफ्टरनून।
मैम मैं जानना चाहती हूँ कि हम लोगों का प्रैक्टिकल एग्जाम कब होगा?
प्रैक्टिकल एग्जाम को देखो, प्रैक्टिकल सेशन पहले क्लिनिकल प्रैक्टिकल होगा, क्लिनिकल का, क्लिनिकल के बाद ही एग्जाम 2 दिन रखा है, 033, 034। तुम्हारा पहले स्पेल में तुम लोग आओगी, क्लिनिकल कर कर जाओगी घर को, फिर
मैम
सेकंड स्पेल में
क्लिनिकल मैम
आओगी।
कब होगा मैम?
2 स्पेल
कौन
है
सा मंथ?
तुम्हारा, ईच बैच में 2 स्पेल है। फर्स्ट बैच में सभी बच्चे आएंगे, क्लिनिकल करेंगे, क्लिनिकल ड्यूटी कंप्लीट कर कर जाएंगे। फिर सेकंड में कुछ क्लिनिकल है, क्लिनिकल के बाद 2 दिन एग्जाम है।
मैम एक्चुअली मैम कब होगा वो क्लिनिकल जो ड्यूटी होता है हम लोगों का?
वो तो अगस्त महीने से स्टार्ट होगा। वो
ओके
3
मैम।
बैचेस में डिवाइड हुआ है। ऑल टोटल बच्चे 90 प्लस है हमारा सेंटर में। ओके,
ओके मैम। ओके ओके मैम।
90 एबव है। उसको 3 बैचेस में डिवाइड किए हैं। 3 बैचेस में 1 से 30, एक बैच 31 से 60, 61 से ऐसे डिवाइड हुआ है। वो सब हम लोग मेल में दे देंगे, तुम लोग को मिल जाएगा, कुछ प्रॉब्लम नहीं है, शेड्यूल भी मिल जाएगा, उसी हिसाब से तुम लोग आना है।
मैम एक्चुअली हम लोग अभी पोस्ट बेसिक कर रहा है, पोस्ट बेसिक सेकेंड ईयर में है। तो हम लोग का वो जो एग्जाम होता है, एग्जाम सितंबर में ही है, फाइनल एग्जाम। तो
हाँ हाँ
इसलिए हम
हाँ
लोग सोच रहे हैं कि कैसे जाएंगे उधर।
हाँ, वो तो बहुत प्रॉब्लम है, पोस्ट बेसिक का एग्जाम फिर इसका प्रैक्टिकल। नहीं तो तुम लोग शिफ्ट कर सकते हो। इसी बार फास्ट फेल में नहीं आए, कुछ प्रॉब्लम है, जो प्रॉब्लम मुझे बताया वो तुम लोग चिट्ठी से इन्फॉर्म करोगे सेंटर को। तो हमारा एनुअल एग्जाम है, इसलिए हम नहीं आ सकते। तुम्हारा इग्नू सेंटर में एग्जाम है पीपीपीएससी और डायरेक्ट एग्जाम है?
मैम डायरेक्ट नहीं नहीं, इग्नू में नहीं है, हम लोग वेस्ट
हाँ,
बंगाल में ही कर रहे हैं।
वेस्ट बंगाल में डायरेक्ट कॉलेज में एग्जाम है, तो तुम लोग नेक्स्ट फेल में आ सकते हो।
मैम
फर्स्ट
मैम
फेल
नेक्स्ट
नहीं तो
नेक्स्ट जब
सेकंड
एग्जाम,
फेल में। हाँ,
मैम नेक्स्ट जब एग्जाम होगा वो सितंबर का बाद होगा या पहले होगा?
नहीं एग्जाम तो ईच बैच का एग्जाम जो स्पेल में जो बच्चे आएंगे 30 30 30 ऐसे ही बच्चे को डिवाइड ही है। तो बच्चे जैसे आएंगे उसका फर्स्ट स्पेल खत्म होगा, सेकंड स्पेल के बाद ही एग्जाम होगा। तो फर्स्ट स्पेल में एग्जाम नहीं होगा। ओके, 20 डेज के प्रोग्राम है फर्स्ट स्पेल, 18 डेज का प्रोग्राम है सेकंड स्पेल। एवरी बैच दो 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 स्पेल में आएंगे। ओके, वो आपका रोल नंबर 1 से था, 1 से 30 और 31 से 60, 61 से 90 से होगा ना रोल नंबर। जैसे रोल नंबर आएगा, जैसे नेम आएगा, उसी तरह हम लोग उसको डिवाइड किए। ओके,
एक्चुअली जो ग्रुप का जो ऑफिशियल जो
हाँ,
ग्रुप है ना, हम लोग कुछ लोग उधर ऐड नहीं हुआ है, तो प्लीज काइंडली
और
अगर आप ऐड
हम
कर
स्टार्ट
देंगे
कर
तो अच्छा
देंगे,
होगा।
और मेल आईडी भी सभी का है, कॉन्टेक्ट नंबर भी हमारे पास है, सब कुछ है। हम लोग वो ग्रुप में दे देंगे, और नहीं तो ईच पर्सन के लिए मेल भी जाएगा, मेल आईडी।
ओके ओके मैम। ओके मैम।
शेड्यूल सभी को देंगे।
ओके
ओके,
मैम, थैंक यू मैम, थैंक यू मैम। ओके मैम।
और एनी क्वेश्चन?
मैडम ये जो असाइनमेंट है 2025 का, ये BSN 032 वाला यही मंथ का लास्ट डेट दिया है, तो इसमें सबमिट करना है, नेक्स्ट मंथ में सबमिट करने से भी होगा? ब्लॉक 2 वाला।
हाँ, जितना जल्दी करोगी उतना अच्छा है। इसी मंथ में दिया हुआ है, इसी मंथ में कंप्लीट हो जाएगा तो अच्छा है, नहीं तो नेक्स्ट मंथ में दे देना।
नहीं, क्योंकि ब्लॉक 1 का अगस्त में दिया है, ब्लॉक 2 का अभी दिया है।
हाँ, तो 0,
सिस्टेमिक का बाद में दिया है, प्रिंसिपल्स का बाद में दिया है।
31, 31, 32, दो दो असाइनमेंट है ना, 31 32 का।
हाँ हाँ, ये प्रिंसिपल का
हाँ
अगस्त महीने का दिया है डेट, और जो सिस्टमिक डिजीज वाला है वो इस
हाँ
मंथ का दिया है।
हाँ हाँ, जो कंप्लीट होगा उसको दे दीजिए, अच्छा होगा। क्योंकि असाइनमेंट और ये सब लेट लेट होने से वो रिजल्ट आउट होने भी बहुत लेट हो रहा है। इसीलिए हम लोग चाहते हैं जल्दी जल्दी देने से तुम्हारा वो करेक्शन हो जाएगा। तुम जब भी आओगी सेल्फ असेसमेंट, सेल्फ एक्टिविटी, सुपरवाइजर एक्टिविटी दे सकते हो। ओके, असाइनमेंट का जल्दी देना है। तुम नहीं कर सकते हो तो अगले महीने भी दे दो, प्रॉब्लम नहीं।
थैंक यू मैम।
हाँ, हेलो।
Okay, ma'am.
Thank you. Now we will close the session. Any doubt? Anyone? Any doubts?
No.
Okay. Okay. Close the session. Okay. Thank you. Today's class.
इग्नू में पोस्ट बेसिक कोर्स है मैम?
हाँ हाँ बताइए।
इग्नू में पोस्ट बेसिक कोर्स है?
नहीं नहीं, हमारा यहाँ पहले था, लेकिन यहाँ डिस्टेंस कोर्स दिए हैं और CFAID जेनेटिक केयर ये सब कोर्स है, लेकिन पोस्ट बेसिक हमारा कॉलेज में नहीं है इग्नो का। इग्नो का अदर कॉलेज में है, वेस्ट बंगाल में है और जो अलग अलग सेंटर राजस्थान और दूसरे दूसरे
वेस्ट
सेंटर
बंगाल
में।
में है डिस्टेंस में?
हाँ हाँ डिस्टेंस में है हमारा।
ईयर
ओडिशा का
2
सेंटर
ईयर का है ना, देखा रहे 3 ईयर का देख रहे?
3 years डायरेक्ट
वही बात
कोर्स।
है।
हमारा कॉलेज प्रोग्राम है 2 years का, लेकिन इग्नू का 3 years कोर्स है।
यही तो बात है। तो सर्टिफिकेट वैल्यू होगा मैम 3 ईयर का?
बहुत वैलिड है हमारा। यहाँ का सभी ट्यूटर भी इग्नो पास आउट होकर तो वो तो प्रमोशन मिला है उसको, कुछ प्रॉब्लम नहीं है। हमारा डायरेक्ट कोर्स जितना वैलिड है वो पोस्ट बेसिक का भी उतना ही वैलिड है। पोस्ट बेसिक का ज्यादा
और एक बात मैम, वेस्ट बंगाल में जो गवर्नमेंट के स्टाफ नर्स का जो हर साल का निकालता है उसमें 5 मार्क्स एक्सपीरियंस का है, मतलब 1 ईयर का कोर्स में, तो डिप्लोमा डिसीजन में देगा डिस्टेंस में?
हाँ हाँ वेस्ट बंगाल स्टूडेंट तो बहुत ज्यादा है डिसीजन का, क्योंकि पिछले बैच जो भी आए हैं 115 स्टूडेंट आए थे पिछले बैच, और उसका प्रीवियस बैच 26 ओनली बिलोंग्स टू वेस्ट बंगाल। बहुत ज्यादा स्टूडेंट, और वो भी बताते हैं डिसीजन कोर्स के बाद उसका इंक्रीमेंट सब कुछ मिला।
ठीक है, थैंक यू मैम।
मैम प्रैक्टिकल सेशन के लिए एक बार बताइए ना, प्रैक्टिकल का कब होगा, कहाँ पे होगा?
अगस्त महीने से शुरू होगा, लेकिन उसका शेड्यूल भी बना हुआ है। वो सेंटर को गया कि नहीं गया, हम लोग उसको ऑलरेडी वी आर शेड्यूल्ड एंड भेज दिया है रीजनल सेंटर।
मेल में तो नहीं है मैम कुछ?
रीजनल को भेजा है, लेकिन मैं पूछकर बता दूंगी। नीचे हमारा वो जो क्लार्क है ना वो
रीजनल सेंटर में ही होगा ना प्रैक्टिकल मैम?
नहीं, हमारा यहाँ सेंटर हो, वो जो स्टडी सेंटर है ना बरहमपुर उसमें होगा, भुवनेश्वर में नहीं होगा। हमारा यहाँ ही होगा, हम लोग ही कंडक्ट करेंगे प्रैक्टिकल। हाँ कुछ प्रॉब्लम नहीं होगा, यहाँ बहुत सब बच्चे आते हैं जाते हैं, खुशी खुशी से सब कुछ अवेलेबल है। यहाँ टर्शरी हॉस्पिटल है, वहाँ का स्टाफ भी बहुत अच्छा है। ICU का कुछ प्रॉब्लम नहीं होगा तुम्हारा। ओके
कि हम लोग का प्रॉब्लम है मैम, इतना दिन टाइम तो प्राइवेट स्कूल में छुट्टी नहीं देगा, यही प्रॉब्लम है।
टाइम
ये थोड़ा
नहीं
मैनेज करना पड़ेगा क्योंकि
ऐसा ही प्रॉब्लम है सभी बच्चे को, लेकिन यहाँ का सिचुएशन अच्छा है, कुछ प्रॉब्लम नहीं है।
तो थोड़ा प्रिंसिपल मैम के साथ बात करेगा मैम, ये प्रॉब्लम है।
हाँ हाँ या ठीक है।
वेस्ट बंगाल से हम लोग छुट्टी तो नहीं देगा ना, क्योंकि प्राइवेट हॉस्पिटल है।
हाँ प्राइवेट तो मिलता नहीं है इतना ज्यादा नहीं।
2-3 दिन छुट्टी देने के लिए 2-3 एप्लीकेशन देना पड़ेगा। ठीक है मैम, थैंक यू। अब थोड़ा देखिए बात करके।
मैम गुड आफ्टरनून।
गुड आफ्टरनून।
मैम मैं हिमांशु दिस साइड। मैम मैंने 2023 में एनरोल किया था DCCN के लिए।
23?
यस मैम।
हाँ हाँ नाम?
तो दिल्ली 3 में मैंने एनरोल किया था, तो मैम वहाँ से कोई कम्युनिकेशन हो नहीं पाया रीजनल सेंटर में, तो उस वजह से मेरा अभी तक कंप्लीट नहीं हुआ था। इस बार मैंने रीटा मैम से बात की थी, तो उन्होंने ये वाला ग्रुप मुझे ज्वाइन करने को कहा था। कह रहे थे आप अभी इस बार काउंसलिंग ले लीजिए। तो BNS-31 मेरा मैम सबमिटेड था उस टाइम पे, और 32 मेरा पेंडिंग है अभी। तो मैम वही पूछना था कि अभी क्या करना रहेगा, मतलब हमारा प्रैक्टिकल्स वगैरह का कैसा रहेगा?
वहाँ प्रैक्टिस दिए है?
नहीं अभी नहीं दिया था मैम, अभी नहीं दिया था मैम कुछ भी। एक असाइनमेंट सबमिट किया था।
अभी तो अभी हुआ है, ये तो फर्स्ट क्लास है।
हाँ जी।
लेकिन यहाँ 25 का कोई प्रैक्टिकल सेशन स्टार्ट नहीं हुआ, अगस्त से स्टार्ट होगा।
ओके ओके मैम।
पिछले बार तुम्हारा मार्क कुछ आए थे, वो जो दिल्ली सेंटर में, जो सेंटर में तुम लोग दिए थे?
नहीं मैम, कोई वहाँ से अभी तक कोई मेल नहीं आता, कोई मैसेज भी नहीं आया आज तक, इसलिए हो नहीं पाया।
किससे यहाँ शुरू होगा?
सॉरी मैम।
फिर से यहाँ न्यूली एडमिटेड है?
नहीं मैम, ये लास्ट ईयर है कंप्लीट करने का, तो इस बार ट्राई किया है
हाँ,
कि हो जाए।
ओके ओके। ठीक है, हम लोग मैम से बात करेंगे।
ओके मैम,
ओके,
थैंक यू।
थैंक यू ऑल ऑफ यू। मैडम कौन कर दे विनायक?